Hi, my name is Annemieke van Damme and I'm a professor at the University of Leuven in Belgium, KU Leuven. And I head the Laboratory for Clinical and Evolutionary Virology and also the Institute for the Future. HIV is a retrovirus because it produces a unique enzyme, reverse transcriptase. I will explain more in a minute. And within this retrovirus family, it belongs to the lentivirus group because of the slow disease development. There are different stages in the life cycle of the virus in which different viral proteins play a role. The infectious viral particle has a membrane in which the viral envelope is anchored. The viral envelope consists of two proteins with GP120 sticking out of the membrane and binding to the CD4 receptor of a CD4 immune cell. These CD4 cells are T helper cells and they're crucial for our immune system. And this binding of GP120 to the CD4 receptor is unique to HIV, so drugs can be developed to inhibit this binding. Once this binding is established, the other envelope protein, GP41, becomes available to bind the co-receptor, which is usually CCR5. But another co-receptor, CXCR4, can also be used. This binding of GP41 triggers the fusion of the viral membrane with the cellular membrane, and this is another drug target. Fusion releases the viral core, in which the viral RNA is packaged into the cytoplasm. So this core transforms into a small factory, so to speak, where cellular components help the viral enzyme, the reverse transcriptase, to copy the single-strand viral RNA into double-strand DNA. This process is very unique and an excellent target for drugs. The double-strand viral DNA remains associated with cellular and viral proteins, and the most important of this is the viral integrase. This complex, the pre-integration complex, enters the nucleus and the viral DNA gets integrated into the cellular DNA with the help of the viral integrase protein. This is another unique process in HIV's life cycle, and it is currently the target of very potent drugs. Depending on the activation state of the cell, the integrated viral DNA can stay dormant, sometimes for years, or in case of activated immune cells, the cell transcribes the viral DNA using its regular RNA polymerases. And the shortest spliced messenger RNA produces the early regulatory viral proteins. Then the longer mRNAs produce structural proteins such as the matrix, the capsid, that are coded by the GAG gene, and the envelope proteins. And other mRNAs produce the viral enzymes, the protease, reverse transcriptase, the integrase. These are produced by the viral pol gene. And the longest full genome messenger RNA also functions as the viral genome. After translation of the viral proteins, the envelope polyprotein homes in on the cellular membrane, and it gets processed by cellular proteases into GP120, the spike, and GP41, the transmembrane protein. So this homing in on the viral, on the cellular membrane results in a kind of button with envelope proteins sticking out, and the viral genomic RNA, which is loosely packed into viral capsid and matrix proteins, homes into this site at the cellular membrane, and this results in a viral budding with the polyproteins, the GAG polyprotein, the GAG pol protein, loosely packed into this budding virus. This is the moment when the viral protease becomes active. And so this immature viral particle that is budding continues to pack the proteins more densely, and the viral protease becomes more active and starts to process the different capsid, matrix, and viral enzymes. We call this maturation. And once all these proteins are fully processed, so cut by the viral protease, we end up with a tightly packed infectious virus particle. So the main activity of the viral protease is during maturation. So this viral protease is another drug target. The infectious HIV particle is now ready to infect another cell, and one activated infected cell can produce a few thousand new infectious particles every few days. There are a few cellular restriction factors that are important in the viral life cycle, and one in particular, ApoBec3, is important for antiviral therapy because it interferes with antiviral drug resistance. So TRIM5-alpha is very efficient at blocking retroviral particles by targeting the viral capsids for degradation. So most retroviruses get cleared in this way. However, the activity of TRIM5-alpha on HIV is rather weak. ApoBec3 and especially ApoBec3G suppresses viral DNA synthesis by inducing a hypermutation in the viral DNA. The HIV Viiv protein counteracts this cellular restriction, and remarkably, HIV actually uses the induced mutations to increase its viral diversity. That's why HIV has a G to A hypermutation rate. Several of the antiviral drug resistance mutations carry the signature of being ApoBec3G induced mutations. SAMHD1 reduces the concentration of nucleotides to the extent that the viral reverse transcriptase activity drops dramatically, and this is most prominent in resting T cells and in myeloid cells. Tetherin is an interferon-induced protein that inhibits viral release, and the viral VPU protein counteracts its activity. Without all these innate cellular defense mechanisms, HIV infection rate and its replication would even be more dramatic. And so these defenses are active the moment the virus infects the cells. So I will now talk about the dynamics of viral replication and disease progression in absence of antiviral therapy. The viremia represents the concentration of viral particles circulating in the body, and the viral load is measured in plasma. During the acute infection, the massive production of virus particles induces an adaptive immune response, including antibody response. And so this response is able to dampen HIV replication within a few weeks of infection. And this can go on for several years. So the CD4 T cell, the immune T helper cells, are the direct target of HIV. And during replication of the virus, they get destroyed. First, there's a drastic drop in CD4 T cells with a subsequent partial recovery once the adaptive immune response kicks in. And then continued viral replication means that there is a gradual CD4 T cell depletion over the years. So while these cells are continuously produced by the bone marrow to replenish this depletion, there comes a time that the bone marrow can no longer preserve the CD4 T cell balance in the blood, and then the immune system breaks down. The most damaging T cell depletion happens in the mucosa. The gut mucosa was shown to be very much affected. Once established, this mucosa T cell depletion is difficult to restore with therapy. So it's really important that we interfere with this depletion early on. So continuous viral replication also means continuous immune activation. And this in turn leads to inflammation and tissue damage. So once CD4 T cell depletion can no longer be restored, the immune system gets deficient and the infected person enters the 8th stage, acquired immune deficiency syndrome. Death follows within months. Without antiviral therapy, HIV infection almost always results in AIDS and death. And an early start of antiretroviral therapy is beneficial because it allows the immune system to recover for a large part, and lifelong successful therapy adds many decades of healthy life. Very early therapy also preserves the mucosal CD4 T cell pool. It limits the size of genetic diversity of the viral reservoir, which is important for resistance development, and it preserves immune function. So starting as early as possible with antiviral therapy is greatly beneficial, but early antiviral therapy also prevents it prevents onwards transmission of HIV. So we have the saying, undetectable is untransmissible. So this is a saying that regards antiviral therapy at population level, trying to reduce the number of infected people. Many of the challenges are related to supporting people living with HIV in being able to take their antiretroviral medication properly. But although these challenges are crucially important, these are not related to the virology and the life cycle of HIV. So let me stress you that HIV is able to quickly develop antiviral resistance because of its capacity to develop and to tolerate high genetic diversity. The mechanisms for this genetic diversity are several-fold. So first, the replication of HIV is very error-prone. Both the viral reverse transcriptase and the cellular RNA polymerase that are involved in reverse transcription and in transcription have no proofreading capacity. So they make many mistakes, many more than DNA polymerases. Another contributor to mutations is ApoB3G, as I already explained. And so the result is that during replication, several mutations occur every single replication cycle. Then secondly, viral replication is fast and extensive. So many replication cycles happen in a short time. Many viral particles are produced, many cells get infected, and this speeds up the accumulation of these mutations. So we say that HIV has a high mutation rate. Now, the virus is affected by this high mutation rate. The majority of the viral particles are defective. They don't function properly because of this high mutation rate. So many mutations basically destroy the virus. But the virions production is so massive that there are enough viral particles remaining that are infectious, that function properly, and so the replication cycle can continue, and the virus is able to infect new individuals and new cells. It also helps that HIV proteins are rather tolerant to mutations. There are large zones in the genome that can accumulate a high genetic diversity without too much damage to the replication of the virus. Then thirdly, when two different viral particles infect the same cell, they can recombine. And so this can be either a result from accumulated diversity within a single person, or it can be because of superinfection. A person is infected with a strain and gets superinfected with another HIV strain. And so when these two different viruses infect the same cell, the pieces of the viral genome can recombine and form a mosaic new genome. So this allows HIV to get rid of parts of its genome that have too many mutations, or to combine successful mutations from different virions into a single virion. So this has been shown to allow the recombination of different drug resistance mutations so that a new virion can be produced with more resistance mutation.
So hello, my name is Jose Rivas. I'm the head of the infectious diseases unit at La Paz Hospital in Madrid. I'm also the research director of HIV and AIDS at the same hospital. And I'm also a professor of medicine at the Autonomous University School of Medicine in Madrid, in Spain. First of all, I have to say that antiretroviral therapy is one of the most efficacious interventions in any therapeutic area in medicine. First of all, it's very important for individual. It prevents disease progression. It actually stops disease progression, and even it recovers the deterioration in immunity that untreated HIV infection produces. But it also has a very important social impact, because people who are treated and achieve an undetectable viral load cannot transmit HIV. Is what we call undetectable equals untransmissible, or U equals U. So these two effects are very important, both for the individual and also for the society. There are many data supporting that an undetectable viral load makes a person not able to transmit HIV. So this translates into improvement in quality of life of persons with HIV, as I mentioned, preservation of the immune function. And also, we know that keeping the viral load undetectable reduces the persistent inflammation and immune activation that some people with HIV can have. So how we monitor this? We monitor this with viral load. We know that an undetectable viral load, it translates into an amazing clinical benefit. Being undetectable means that the process of immune reconstitution can start. And also having an undetectable viral load, as I mentioned, makes us able to tell patients that they cannot transmit HIV. So these are the main important aspects of the effect of antiretroviral therapy, both in the individual and also in the society. So we're very fortunate that we have several classes of antiretroviral drugs. The first class that we have were nucleoside reverse transcriptase inhibitors, such as tenofovir or entrectinib. These drugs mimic natural nucleotides, and they get incorporated into the viral DNA chain, and they are chain terminators. They don't allow the chains to continue growing. We also have non-nucleoside reverse transcriptase inhibitors, such as efavirenz, that we use for many years, and they interfere directly with reverse transcriptase enzymes. We also have protease inhibitors that interfere with the division or the cleavage of the precursor proteins and makes the virus immature. And it's very important that in 2007, we had a great revolution in antiretroviral therapy. We have the approval of the first integrase strand transfer inhibitor, raltegravir, and then they were followed by two very important integrase inhibitors, dolutegravir and bictegravir. That is one of the most used classes of antiretroviral therapy right now, and they block the integrase enzyme, which is required for the integration of viral DNA into the whole genome. But we also have entry inhibitors like CCR5 antagonists, like maraviroc, fusion inhibitors like enfubertide. We seldom use them because they have disadvantages compared to the other drugs. And also we have post-attachment inhibitors like ivalizumab. And also we use some boosters to improve the pharmacokinetics of other drugs such as cobicistat or ritonavir. So we have a great armamentarium of different antiretroviral drugs, and it's very fortunate that we can design regimens even for people who have virus which is completely sensitive to the drugs, and also for viruses who have become resistant. So the rationale, first of all, is that when we combine at least two antiretroviral drugs, we have enhanced efficacy. We say our ability to decrease the viral load improves. We can have very profound decreases in viral loads that are larger when we combine at least two potent antiretroviral drugs. Well, that's one of the reasons, the rationale. The other rationale is that by combining drugs, we reduce the risk of resistance selection. We know that if we have two potent drugs with different mechanisms of action, it's very difficult for the virus to overcome this genetic barrier to resistance. So that's the other very important rationale to combine antiretroviral drugs. We know since 1996 that we follow this rule of combining antiretroviral drugs, we achieve long-term viral suppression. Also, if we have the right drugs in the regimen, we improve treatment adherence for patients. So this is the reason why all expert guidelines recommend combination therapy for HIV. Now there is agreement among all the guidelines that the preferred option is to combine a second-generation integrase inhibitor such as dolutegravir or bictegravir with one or two nucleoside reverse transcriptase inhibitors. We can use, for example, TAF, FTC, and bictegravir, or can use just two drugs like dolutegravir and 3TC. And I have to say that this has really revolutionized HIV therapy, because these drugs, when used in people who are antiretroviral naive, have an extremely high barrier to resistance. It's very difficult for the virus to become resistant to this combination. Other recommended combinations is two nucleosides plus one non-nucleoside reverse transcriptase inhibitors, such as, for example, the doravirine. And the other very common recommendation, mostly for people who have resistance to integrase inhibitors or non-nucleosides, are two nucleosides and a boosted protease inhibitor. So we have to find specific aspects of our persons with HIV life, such as age, comorbidities, or drug interactions, to select one of these regimens. But I have to say that these recommended regimens of one or two nucleosides with an second-generation integrase inhibitors are very good options for the majority of the patients. We have new antiretroviral regimens in development, but we have already approved a very interesting combination of two drugs. One is a second-generation integrase inhibitor, cabotegravir, and another is a non-nucleoside reverse transcriptase inhibitor, rilpivirine. And they have been nanoformulated to be able to give it intramuscularly. And this is the first generation or long-acting injectable agents, and this combination can be given every 2 months intramuscularly. It's approved for persons with HIV that are virologically suppressed, and for people that for different reasons, like can be difficulties in swallowing, but also very importantly, people who, because of issues of stigma or disclosure, don't want to take oral pills, can be treated just with 6 visits to the doctor every year. So that's that's something that we couldn't even imagine several years ago. So another drug that can be given long-acting is lenacapavir. Lenacapavir has a new mechanism of action. It's a capsid inhibitor and can be administered subcutaneously every 6 months. There is interest in combining lenacapavir with broadly neutralizing antibodies that can be given also every 6 months. So imagine that we can have a regimen that can be administered as infrequently as twice a year. We have also islatravir, that is a nucleoside reverse transcriptase translocation inhibitor, and its pharmacokinetics allows for once weekly or once monthly dosing. Islatravir, along with lenacapavir, both orally and once weekly, have entered clinical trials, and we've seen the first clinical trials of this combination. That is a oral long-acting, oral once weekly, that can be very interesting for many patients. Islatravir also has the potential to be given even more infrequently by other routes of administration, even can be given once monthly. And there are other drugs on development, other capsid inhibitors. As I mentioned, broadly neutralizing antibodies are trying to find its role in HIV therapeutics. We have to test upfront for sensitivity, but they have the advantage that also, as I mentioned, can be given very infrequently. And we have other non-nucleoside reverse transcriptase inhibitor that have the potential for once weekly, and also for people who have virus which is multi-resistant, we have maturation inhibitors. So the basic take-home message is there is a pipeline, and this pipeline is specifically designed for many of the drugs of the pipeline to be given as long-acting regimens.
Hello everybody, my name is Antonella Castagna and I'm professor at Vita Salute San Raffaele University. I'm the head of the infectious disease department at San Raffaele Scientific Institute in Milan, Italy. There are many factors contributing to development of antiretroviral resistance. First are factors related to the virus. I mean, there are factors associated with this virus, like high mutation rate, error-prone reverse transcriptase, viral recombination, high viral turnover that make the possibilities to select mutation more easy. And we have also patient-associated factors. I mean, in particular, low CD4 count, the presence of active co-infection, the lack of monitoring correctly the therapy, the poor adherence to the therapy, and then we have also factors associated to some drug. The long exposure to antiretroviral is associated with antiretroviral resistance, or high pill burden, or suboptimal therapy like monotherapy we have used in the past. For sure, there are factors like virus-associated factor and patient-associated factor. I mean, the viral immunological profile of the patient, we cannot change. But there are factors that we can change, that we can favor the adherence to the patient. So, for instance, trying to choosing antiretroviral regimens that are simple, that are well tolerated, that can be able to suppress viral replication, but to assure to the patient a good quality of life, to me is an important factor to assure the maintenance of undetectability. Nowadays, we have antiretroviral regimens that are very effective, well-tolerated, simple, but I believe that we need to know the story of the viral profile of the patient and antiretroviral resistance since the beginning. So I think that we need to look at the genotype test before starting antiretroviral therapy and after if the patient fail. And the reason, because we need to follow very accurately the patient, is because health failure, antiretroviral failure, is associated with an increased risk of progression to AIDS and mortality, a reduced quality of life, and an higher risk of failing subsequent therapy, and also to further development of drug resistance. So to me, it's very important that we start with effective, easy to take, to be taken, well-tolerated antiretroviral regimens in order to prevent antiretroviral failure in patients. And the goal of preventing antiretroviral failure and the development of resistance is very, very important even today. We can differentiate two moments. One is the evaluation of resistance before the initiation of antiretroviral therapy. We know that the testing and even the testing for resistance should not delay the initiation of antiretroviral therapy, but to me it's very important to have collected the face of the virus before starting antiretroviral therapy in order to have the possibility to come back to the initial virus if you fail. I think that the pre-treatment drug resistance today is quite rare in my experience, but we have to pay attention to the fact that some patients may harbor a different subtype than the B subtype. Some patients can have been exposed to suboptimal therapy. So it's really important that even if it's rare, you do the genotype before the initiation of antiretroviral therapy. It's rare, but when it's present, it gives you very important tool in order to follow the patient in the future. And the second part, the second moment is the antiretroviral test, the genotypic resistance test during antiretroviral treatment. And I think it's very important to manage when you have a patient who has incomplete suppression or a patient who were undetectable, who wasn't detectable and had a viral rebound. So we have to evaluate all the factors we mentioned before, evaluating adherence, tolerability, drug-drug interaction, and do the genotypic resistance testing in order to have all the elements to decide if there is a need to change therapy or not. And we have also some special consideration about special population, I mean pregnant women, PEP exposure, and I think it will become more and more important in the future in the context of pre-exposure prophylaxis failure. When we have done genotype in a patient who develop antiretroviral failure, viral failure, we can have three situations. One, genotype is not, the results is not available. The second one, the genotype, we don't see mutation at the genotype. And in the third case, we can see mutation at the genotype. This is perhaps the easier situation. And we can divide what to do with the patient, considering that we can have a patient with limited resistance and we can have a patient with multi-class resistance. The general principle is to use at least 2, preferably 3 fully active drugs in the new regimen based on the resistance mutation. And of course, if you have a limited resistance only to an RTI in the early phase of HIV infection, the new regimen is usually included 2 NRTIs plus 1 active PI booster or second generation integrase, bictegravir or dolutegravir. More complex is the situation if you have a multi-class resistance, if you have a lot of failure in the past. One of the milestones in this scenario is to use 1 fully active boosted PI together with a second generation integrase inhibitor, or it can be the situation where you have only 1 or 2 fully active drugs and you have to combine this fully active drug with the residual activity of other remaining drugs. We have a discussion when to change therapy in patients who have limited option. If less than 2 active drugs are available, there is the possibility to delay the intervention, but in my opinion, now with the good new option we have, the goal for this patient, even in those who have a low CD4 count, but even high CD4 count, is to achieve once again the detectability. So in my experience, I will not delay. If I have option, and now we have option an increased panel of options in order to achieve the detectability and maintain the detectability during the time. We know the treatment interruption is not more recommended, it should be discouraged. And we know that in some particular cases, when you don't have 3 active drugs, continuation of TTC or FTC may be beneficial for the patient. And I think that whenever you change the regimen, is really important that you consider, that every physician should consider, other than the activity of the drug, other components that are very important in order to achieve a detectability. And to me, one important is the simplicity of the regimen, as much we can, the possibility to have the possibility that our regimen will fail because of drug-drug interaction or because of toxicity risk evaluation. The other point is that we have to discuss with the patient a strategy. So including the possibility of the regimen we are providing to sparing new salvage the regimen for the future. It's not just the regimen we are changing. In discussing with the patient what option the patient have are remaining fully active option and how to use them now and in the future. In the treatment naive, we see very few cases of resistance, also because now we have some option like integrase inhibitor of second generation that are able to cover some little resistance we found. The other point is that we, as a center, we are concentrating patients with multidrug resistance from all over the country. So we are able to manage, we are used to manage patients with limited therapeutic option. And I would say that patients with limited therapeutic option are still very rare, are 1, 2, 3 patients in every center. But for this reason, we need to face this patient with a multidisciplinary approach in order to find to this patient the best solution. And multidisciplinary approach means to talk with the virologist, with the pharmacologist, with the, if the patients has comorbidity, also with the specialist because of drug-drug interaction. So the patients with multidrug resistance are rare, but they need to be followed in a proper way, very accurate way. And presence of resistance is one of the main drivers for try to achieve this virological success, even in these patients.